moving right along, Matt Schulz is going to deliver this month's Operational Excellence presentation, and he's going to talk a little bit about Jakafi.
Hey folks, thank you so much for your patience today. We really appreciate you tuning in and helping us to share information and best practices across the country. I'm grateful to be presenting today a little bit about Jakafi, or Jakafi, potato, choose your pick. I'm going to go with Jakafi. Among the discussion today, we'll review polycythemia vera, the way it fits in the JAK pathway, if it's safe and efficacious. And then I decided to take it a little step further beyond just a usual PI discussion and talk about actually implementing use of this drug in practice by using one of NCODA's initiatives, the PQI. Next slide, please. So the disease state as a whole, polycythemia vera is actually a slow-growing blood cancer, and it currently impacts about 100,000 patients here in the United States. The average age of diagnosis is 60, which is a fairly young population. Most of them present with symptoms. These are range from concentration problems, itching, muscle bone pain, fatigue, and definitely reduce the patient's quality of life and interfere with their daily activities. A third of those patients are diagnosed after a thrombotic event, such as a stroke or a DVT or an MI. As we know, those things can be fatal. Next slide, please. The JAK pathway in itself is a chemical signaling pathway, and it plays a role in production of erythrocytes, thrombocytes, and leukocytes. And overproliferation or activation of that pathway leads to increased production of those blood cells. So as you can see on the surface of the cell, as a cytokine comes in to activate, it does get that pathway going and leads to production of those blood cells. And that in itself is what leads to all of the factors contributing to PV. Next slide. Well, why does that matter? It turns out that really up to 97% of patients with PV have a JAK2 mutation. That's a pretty large number. In fact, it's much greater than those who have myelofibrosis, and it does point out the need for a medicine that would limit that mutation. And next slide, please. So what is that drug? Well, it's Jakafi, believe it or not. That is a kinase inhibitor of both the JAK1 and JAK2 enzymes. It has a couple of indications. One, for the treatment of patients with polycythemia vera who have had an inadequate response to or intolerant of hydroxyurea. The second indication is for myelofibrosis. We won't be discussing that one today, but that was the first indication and what you're all mostly familiar with. Next slide, please. This indication was approved via the RESPONSE trial. In that trial, they set ruxolitinib or Jakafi against best supportive care, assessing patients with polycythemia vera for hematocrit control and spleen response. They also looked at secondary endpoints, including symptom reduction. And if we go to the next slide. To orient you, here on the left side, we have the composite of the endpoints, and on the right side of the dotted line, you have the two endpoints, the first being spleen volume reduction, the second being hematocrit control. As you can tell, the blue bar, which represents Jakafi, far outweighs the orange gold bar. In fact, you can't even see it in a couple of them, thus showing that ruxolitinib was indeed superior to standard care in reducing spleen volume and hematocrit control. Next slide. And something that we think more about is well, how does the patient feel? And this, maybe is more important to all of us who care for patients every day. And again, as you can tell, the blue bar far outweighs the gold, and this includes symptoms of the tiredness, itching, night sweats, headache, dizziness, vision problems. Tinnitus is also common. As you can tell, the ruxolitinib arm did do better, and it did help those patients have a reduction in their symptoms. Next slide. Beyond efficacy, we always need to look at safety. As you can see, the two arms, ruxolitinib versus standard therapy, are very comparable. These are the non-hematologic adverse events. Things you might see most often include muscle spasms or dyspnea or itching, and a lot of that, again, is just the disease state itself. Next slide. These are probably the more important side effects, perhaps more rare, but potentially more dangerous. So It's a reduction in really all of the blood cell numbers. You know, polycythemia vera, you have too much of these things, and if you swing it the other way, you'll have too few of them. Most important of which would be our lymphocytes and leukocytes, and obviously this will all be monitored via CBCs, but these are important things to keep in mind when utilizing this medicine. Next slide. In summary of that trial, again, the Jakafi or ruxolitinib was superior to standard therapy, and we do need to look out for some of those grade 1 and 2 issues of low platelets, dizziness, low red blood cells, and bruising. And more serious would be the lymphopenia, potential for infections, and even new skin cancers. Next slide. Now, here comes the fun part. I'm really curious what everybody's doing in practice with this drug. One of the ways that we as pharmacists can provide value back to our practice and our patients is by utilizing the PQI, or positive quality interventions. As you can tell, we have a lot of them, and I would urge everybody to look at them. But there's one in particular called Managing Treatment of PV, and we're going to go into that in a little more detail. If you go to the next slide, please. Please don't read all these words. There's too many, but this is actually the PQI just spelled out for everyone to be able to see kind of how we lay these out. Really, we're just identifying patients who haven't had a proper response to treatment, and we want to prevent those cardiovascular events and improve quality of life. Next slide. Part of that review process, it's been determined that keeping a hematocrit in the range of 45 to 50% would lead to 4 times greater risk of cardiovascular events. So the goal is always to keep the hematocrit under 45%. And interestingly, anywhere between 20 to 60% of patients who are on Hydrea are not having a proper response. And therein is the point for us to intervene and help patients get a medicine that's actually working. Next slide. So part of this process is to, of course, look at the CBCs, be monitoring those. If patients are above a hematocrit of 45 and they are low risk and have not been initiated on Hydrea, we may want to consider doing that. For those patients who are high risk, have been on hydroxyurea for longer than 12 weeks, they're still getting phlebotomies, aka they're not responding, those would be great candidates to switch. And in that case, you may want to ask the prescriber if they want to consider using Jakafi starting at 10 milligrams twice a day. And next slide. Of course, starting a patient on new medicine, we want to follow up with their adherence. Most importantly with this, we're going to be monitoring CBCs and providing education to the patients about how it works and what to look out for, including infections and monitoring their own skin for any new skin lesions, etc. And next slide. Very quickly, what we're doing here at our practice, Rocky Mountain Cancer Centers, we're a large practice in Colorado, 13 different treatment centers, about 80 prescribers, and about 45,000 lives touched every year. We review charts. All of our hydroxyurea patients can take a look at those using those PQI criteria. Anybody with a hematocrit over 45 or worsening symptoms after being on hydroxyurea may be a candidate. So those we do recommend to the prescriber to consider changing, and of course always leaving it up to them what's best for that patient. Now, does anybody have any particular practices they're doing or implementation or use of this drug that they'd care to share as well? I know we're running over time, so everybody's probably anxious to get back to their busy jobs. Appreciate you all hanging around. Just to conclude, again, there's a significant amount of patients taking a medicine that's maybe not doing them much good. Herein is the opportunity for us as providers to help patients utilize the PQI, improve quality of life, and really prove value from the pharmacy team for bringing awareness into this disease state. I'd be happy to take any questions or comments, and again, thank you all for your time.
Great, thank you, Matt, and thank you again to Insight for sponsoring our operational excellence presentation this